Welcome to Rate and Rhythm Disorders. Now the first thing is what happens with the sinus node. Most of the things that happen with the sinus node at the beginning is really sinus bradycardia. When you have sinus bradycardia, sinus brady and sinus tachycardia, the management of sinus bradycardia is almost exclusively what's the management of the underlying cause. Well, by definition, the heart rate normally runs between 60 to 100 beats a minute. That's a normal heart rate. If it's under 60, it's bradycardia. Well, what happens mostly with sinus bradycardia is that you could be a marathon runner. Well, you could just be excessively trained. You could be on a medication like a beta blocker, a calcium blocker, digoxin, that blocks down the RSA node. However, the management of sinus bradycardia, if there's no symptoms, is what is the management of the underlying cause? Now, if you have a person that has a sinus bradycardia and has symptoms, even if it is some marathon running or swimming or some form of thyroid problem like this, if you have acute symptoms, acutely symptomatic, the acutely symptomatic patient is managed first with atropine, and if the atropine doesn't work, a pacemaker. Depends on what the etiology is, except if you're symptomatic. If you're symptomatic, well, symptomatic people need to get atropine. What's the symptoms of bradycardia? Lightheadedness, hypotension, woozy, disoriented. No symptoms, no treatment. Sinus bradycardia, symptoms, atropine, the best initial treatment. Pacemaker, most effective treatment. Now, if the symptoms don't get better with atropine, you would use a transcutaneous pacer, acutely. If the symptoms don't get better with atropine and the transcutaneous pacemaker doesn't work, transvenous pacemaker. Sinus bradycardia, no symptoms, no treatment. Yes symptoms, atropine followed by pacemaker. Now, first degree block, second degree block, and third degree AV block. First degree AV block means a big nothing, no treatment. Second degree AV block means that if it's Mobitz 1, no treatment. Mobitz 2, a pacemaker. And that's the divided line here. First degree AV block gets nothing. Second degree AV block, if it's a Mobitz 1, gets nothing. If it's a Mobitz 2, you have to put in a pacemaker. Pacemaker, make me a match. There, third degree AV block, pacer. Third degree AV block, pacer. Now, first degree AV block, our PR is greater than 200 milliseconds. Well, the most common reason for most of these rhythm problems is the conduction system becomes a little ischemic, a little crotchety, a little old. It's like hair loss, gray hair. What happens? If there's no symptoms, you leave it alone. First degree AV block, see where the QRS is a little bit big? The PR interval is a little prolonged, where the PR is a little bit prolonged like this. When the PR is somewhat prolonged, you don't do anything about it. It doesn't get worse. Mild PR prolongation does not progress to getting any worse than it is now. First degree does not go on to becoming second degree. Second degree doesn't automatically go to third degree. Mobitz 2 progresses. Mobitz 2 gets worse. Mobitz 2 evolves. Mobitz 2 progresses, Mobitz 2 gets worse, Mobitz 2 evolves. So therefore, ready? Mobitz 2 gets worse, Mobitz 1 goes nowhere. Symptomatic, atropine. Symptomatic, atropine and pacemaker. Asymptomatic, do nothing. First degree AV block, prolonged PR, do nothing. Second degree AV block, the Mobitz 1 is a wanky buck. Mobitz 1, the PR gets longer and longer and longer and drops longer and longer and longer. It drops. Although I wouldn't like my PR to get longer and longer and longer and drop, PR progressively prolonging with the wanky buck means that you have a person that is just aging in the conduction system. They don't need therapy. But they're dropping. Yes, but they're just aging in the conduction system. They don't need therapy. Mobitz 2 is much worse. It doesn't progressively progress, it just gets to dropped beat. Now here's Mobitz 1. See this PR? Then this PR gets longer, then this PR gets longer, then drop. You don't have to do anything about it. No therapy for Mobitz 1. The PR gets longer and longer, drop. Whereas Mobitz 2, it stays fixed, and then just dropped. Mobitz 2, whether you're symptomatic or asymptomatic, you're getting a pacemaker. Mobitz 2, whether you're symptomatic or asymptomatic, you're getting a pacemaker. Mobitz 1, no pacemaker. Mobitz 2, a pacemaker. Third degree AV block. See these P to Ps? P to P, P to P, that's a P, that's a P, that's a P, everywhere a PP. Old MacDonald had an EKG. P-O, P-O, P. You see that? The P to Ps are constant. The R's to R's, the R to R, the R to R is constant. No matter what the symptoms are, and when you have a third degree AV block, the third degree AV block must always get paced. You could have a sudden loss of consciousness. That's a Stokes-Adams attack. I'm walking down the street, I'm feeling fine. And then two Irish guys named Stokes and Adams. One is in 1828, the other in 1847 in Ireland. In between pints of Guinness, find me passed out on the floor. These guys described bradycardia, hypotension, and canon A waves. Bradycardia, hypotension, and canon A waves, Stokes-Adams attack. If they're acutely symptomatic, atropine. If no matter what happens, pacemaker. Pacemaker, just atropine first if you're acutely symptomatic. A Stokes-Adams or Adams-Stoke attack is the sudden loss of consciousness from hypotension brought on by third degree AV block. Now, supraventricular arrhythmias are much less dangerous. Supraventricular arrhythmias are much less dangerous because you don't live off your atrium. You don't live off your atrium. Supraventricular arrhythmias are much less dangerous because you live off the ventricle, not off the atrium. Sinus tachycardia is always managed by managing what's the underlying cause. So what's the underlying cause of making my heart beat? What makes my heart beat so fast? Maybe I'm just in love. Well, it could be, because the etiology of sinus tachycardia is the etiology of give me all the diseases in the world that make me uncomfortable. I'm in pain, I'm in fear. I'm in fever, I'm in anxiety. I have hypoglycemia, I have a fever. Anything that causes increased catecholamine output. So that's almost like telling me anything, any disease, like what makes a sinus tach? You sick. You sick with what? Name it. Name it that make you sick. From hypotension to congestive failure, from a pulmonary embolus to anemia, and all the psychological problems in the world. But paroxysmal supraventricular tachycardia is different because sinus tachycardia has a P wave. Sinus tachycardia has a P wave. And supraventricular tachycardia has no P wave. And that's the big deal here. Has ectopic, in other words, it is basically a circle around the AV node, but no P wave. There's no P wave to it and you're tachycardic. Now remember, atrial tachycardia and supraventricular mean pretty much the same thing. Atrial and supra. Supra means above. Ventricular, above the ventricle. What's above the ventricle? The atrium. So atrial tachycardia and supraventricular tachycardia pretty much saying the same thing. Re-entry means that as you're going from the SA node here down to the AV node here, well, what's happening is that you're having a circle of re-entry around, around the AV node. And what's ended up happening, that's why you have no P waves, no fibrillatory waves, and no flutter waves. It's circling around the AV node. Now, this thing is on average SVT. On average, SVT is around a rate of 160. That's one of the reasons you can know it's an arrhythmia. You got a 70-year-old guy with a rate of 160. 220 minus the age. How does a 70-year-old guy get to a heart rate of 160? He's got an arrhythmia. Now, SVT SVT, supraventricular tachycardia, if someone is stable, the first thing is vagal maneuvers. Vagal maneuvers try to block down that AV node. What's your favorite vagal maneuver? Yeah. Carotid sinus massage, Valsalva dive, dunk their head in a bucket of ice water, flush their head in the toilet, increase that vagal tone. Just don't do eyeball pressure because it will detach the retinas. Vagal tone. If the vagal maneuvers don't work, then it is adenosine. Now, what else besides supraventricular tachycardia does adenosine work on besides SVT? And the answer is nothing. Adenosine is a one-disease drug. Adenosine is an SVT drug, period, only, solamente, nada más. Adenosine is a one-disease drug. Now, cure, you see that word cure? Breaks 90% of cases of SVT. Cure breaks 90% of cases of SVT. Cure breaks 90% of cases of SVT. Now, if you don't get better with adenosine, then you have several choices of drugs that you could use for atrial arrhythmias. You have beta blockers, atenolol, metoprolol, atenolol, calcium channel blockers, and digoxin. All of these work for atrial arrhythmias. But remember, there are a lot of calcium blockers, but only diltiazem and verapamil work on people with supraventricular tachycardias. Only people who have verapamil and diltiazem work on supraventricular tachycardias. Beta blockers, calcium blockers, digoxin. Beta blockers, calcium blockers, digoxin. All of them will work on slowing atrial arrhythmias, but only adenosine for SVT. Digoxin, digitalis, some places call it digoxin, some digitalis, don't get fooled. They're the same damn thing. Synchronized cardioversion if unstable, what does unstable mean? It means we're not perfusing my brain, I'm confused. What does it mean by unstable? Not hypotensive, hypotensive. What does it mean unstable? Short of breath. What does it mean unstable? Chest pain, shortness of breath, hypotension, confusion. Chest pain, shortness of breath, hypotension, confusion. Shock it. Now, all cardioversions are synchronized except VFib. So synchronized means this. P, QRS, T. This is repolarization. We do not want to deliver electricity during repolarization. It can make it worse. What's worse than SVT? VFib. What's worse than SVT? VTAC. What's worse than SVT? Asystole. I was worried about my bad rhythm till I met a man who had no legs. I was worried about my bad rhythm till I met a person in asystole. He was dead. Shock if you're unstable. What does unstable mean? Chest pain, shortness of breath, hypotension, confusion. Means you're not getting enough perfusion. Oh yeah, baby. Capillary refill. Pale, sweaty. Ay, Dios mío, ay, qué lástima, ay, doctor. Sweating, yo tengo mareo. No. Real stuff. Chest pain, hypotension. Urine output takes too long. Urine output, too slow. I need to know now. Can't wait for urine output. Multifocal atrial tachycardia. Multifocal atrial tachycardia is another type of atrial arrhythmia. Multifocal atrial tachycardia is multiple P-wave morphologies. You're still originating out here somewhere, but it's not reliable. It's not reliable. It's basically an atrial rhythm disorder, multifocal atrial tachycardia, secondary really to one disease, COPD and respiratory disease. That's why MAT is not managed with beta blockers, because the people who get multifocal atrial tachycardia are pretty much exclusively respiratory disease people. 3 different P-wave morphologies, secondary to COPD, digoxin or calcium blockers, please. 3 different P wave morphologies, multifocal atrial tachycardia. Secondary to COPD, fix the lung disease, give calcium blockers. It's all with respiratory. Multifocal atrial tachycardia. See, it's narrow, the QRS is less than 100 milliseconds. A QRS of under 100 milliseconds is normal for sure, even up to 120 milliseconds. Remember, each of these small boxes here, each tiny box is considered to be 40 milliseconds. Each of these big boxes is 200 milliseconds. So this QRS, a QRS should normally be definitely under 120 milliseconds. So this is a narrow, complex tachycardia. But you see, the P waves are different sizes and shapes. Multifocal atrial tachycardia. 3 different P wave morphologies secondary to COPD. Fix the underlying disease. 3 different P wave morphologies. P, looking different. Fix the COPD. Multifocal atrial tachycardia. No beta blockers. Atrial flutter. 1, 2, 3, go through. 1, 2, 3, gets through. You notice how these flutter waves look the same, and these flutter waves look the same, and these flutter waves look the same? Flutter waves are hairline regular and reproducible. Flutter waves, flutter waves, unlike MAT, flutter waves always look the same. It's another type of atrial arrhythmia, but the flutter waves always look the same. The management is largely the same, which is beta blockers, calcium blockers, and digoxin. No adenosine. Why? Because adenosine is only for supraventricular tachycardia. So atrial flutter is still a narrow or normal complex tachycardia. Because it's a narrow complex tachycardia, it can be managed with beta blockers, calcium blockers, and digoxin, which slow down the AV node. They all block down the AV node. But atrial flutter, the flutter waves are reproducible. The flutter waves all look the same. That's the difference. The other thing is atrial flutter. If it's unstable, you shock. Synchronized cardioversion. What do we mean by unstable? Chest pain, shortness of breath, hypotension, confusion. Means you're not getting enough perfusion. That's correct. So atrial flutter is shocked if it's unstable. Remember, synchronized cardioversion, keep the electricity off the T wave, off of repolarization. Digoxin and calcium channel blockers and beta blockers are all the 3 drugs to slow it down. Now, AFib, the most common arrhythmia in the United States, AFib. From a big left atrium, atrial fibrillation. From hypertension. I have a cardiomyopathy that's dilating from a dilated left atrium. You have basically an atrial arrhythmia. QRS is normal, QRS less than 120 milliseconds. You have atrial depolarization that's occurring like a seizure. It's very disorganized. If the atrium doesn't work, the P waves are completely lost. You have fibrillatory waves, which is like a seizure. You ready? Fibrillatory waves, totally random. Flutter wave, totally regular. MAT, in the middle. 3 morphologies, but not totally random. Ooh, this flutter is too regular. Ooh, this fibr is too irregular. Too irregular. Ooh, this MAT. 3 morphologies. So what do we have? P waves. No P waves, no fibrillatory waves, no flutter waves. 3 different types of P waves. Flutter waves, like a sawtooth pattern, hairline regular. Fibrillatory waves, the atrium's having a seizure. Most common etiology, hypertension. If it's unstable, shock it. If it's unstable, shock it. So we look at AFib here. We see at the R to Rs, R to Rs, R to Rs, very irregular. We see here, wow, look at those fibrillations, man. Let's see that. See those fibrillations? Look at that. I hate it when my harmonics are all screwed up. Fibrillations. The atrium's having a seizure. The atrium's having a seizure, man. Look at that. What are you going to do? If they're unstable, shock it. If they're stable, what are you going to do? The thing is that if it's chronic, no matter what the etiology is, You have to anticoagulate it. This is the single biggest change in all the arrhythmic problems in the last 5 years, is that anybody who's got chronic atrial fibrillation, chronic is defined as greater than 2 days, chronic atrial fibrillation greater than 2 days, must get Coumadin or warfarin to maintain an INR of 2 to 3. And the major management of atrial fibrillation is rate control to get that rate under 100 and anticoagulate it. Rate control under 100 and anticoagulate it. Look at this. Bold it and underline it. Risk of embolic events. So that means when you have this AFib like this, see the fibrillatory, when you see that AFib like that, you must control the rate. Rate control to make it asymptomatic, then anticoagulate. If you're unstable with AFib, shock, chest pain, shortness of breath, hypotension, confusion, shock, shock, shock. If you're stable, rate control. With what? Beta blockers, digoxin, calcium blockers. Once you have the rate controlled to under 100, then you are going to anticoagulate it. Now, using drugs to slow the rate, there is no fundamental difference between atenolol, verapamil, or digoxin. All of them are okay. If all of these drugs are equal, how are you going to choose between them? If all of those drugs are fundamentally equal, different medications for different underlying diseases. They give you a patient who's got Graves' disease, you choose a beta blocker. No, your patient has severe COPD. Choose a calcium channel blocker. No, your patient has CHF. Choose a beta blocker. No, your patient has borderline low blood pressure. Choose digoxin. Why? Because digoxin doesn't lower blood pressure. So you use one of these drugs to slow the rate, then anticoagulate with Coumadin. Now, it is occasionally necessary to convert someone. However, I want to be clear here. Routine cardioversion is only for hemodynamically unstable patients. AFib. The majority of people who have AFib are not going to be able to be converted successfully in the long term. Now, there's two choices here. One is, what should you do? You should give rate control with a beta blocker, calcium blocker, digoxin, and anticoagulation for long term. The different question is, if you are going to convert, what do? You do a synchronized electrical shock, and if you are going to cardiovert, you have to anticoagulate the patient so you don't dislodge a clot. Now, these drugs that can be used to pharmacologically convert people, you anticoagulate. Then you see these drugs, amiodarone, dofetilide, ibutylide, propafenone, quinidine. This is a big problem. You ready? Which drugs can be used to convert you? These drugs, amiodarone, dofetilide, flecainide, ibutylide, propafenone. What should you do? Don't convert. What could be done? These drugs can be used to convert. What should you do? Don't convert. You should use drugs to slow the rate and anticoagulate. However, if you are going to convert, these are the conversion drugs. They don't slow the rate. These are the conversion drugs to maintain you in sinus. They don't slow the rate. Now, long-term treatment, you can burn out the source of the ectopic focus with a catheter, destroy the source of the ectopic focus. That's different because that could be a permanent fix. Just shocking someone or using meds to get them into sinus is not a permanent fix. Catheter procedures are a permanent fix. Rate control and anticoagulation is the most important thing. Now let's see, we got a 32-year-old man who comes with shortness of breath. Hypotension, JVD, RALS, AFib, hypotension. What are we going to do? Shock it in the sinus. What are we going to do? Shock it in the sinus. What are we going to do? Shock it in the sinus. Why? Because he's hypotensive and short of breath, congestive failure. This is unstable. Synchronized or unsynchronized? Synchronized. Now, our next case here, a 65-year-old man with palpitations for 2 days. He has palpitations, but palpitations do not constitute hemodynamic instability. Hemodynamic instability is chest pain, shortness of breath, hypotension, confusion. This guy is just rapid. So what do? Control the rate and anticoagulate because palpitations don't count. Now, Wolff-Parkinson-White is an EKG that shows a short PR. When you have an aberrant conduction tract around the AV node, that results in a PR segment that is abnormally short. It's going around the QRS, and that's a PR that is less than 120 milliseconds. A delta wave is a sign of conduction around the normal QRS. And the conduction around the normal QRS results in a short PR. The short PR results in the delta wave. It's conduction around the normal QRS. So therefore, the delta wave results in a short PR or Wolff-Parkinson-White. Now, in Wolff-Parkinson-White, you see this delta wave here? That's a sign of conduction around the AV node. Here are the Wolff-Parkinson-White questions. 1, how to recognize it in a delta wave. Number 2, the long-term therapy is to use radiofrequency catheter ablation to eliminate it. In the short term, if they're unstable, you shock. What do we mean by unstable? Chest pain, shortness of breath, hypotension, confusion. If they're stable but running in fib flutter, SVT and VTAC, procainamide. Now the reason why we're avoiding digoxin and beta blockers and avoiding digoxin calcium blockers is that digoxin and calcium blockers can block down the normal AV node and force conduction around the normal AV node. It can force conduction around the normal AV node. And therefore you get increased Wolff-Parkinson-White, increased SVT and VTAC. In the long term, you use a radial catheter to ablate the aberrant sinus tract, the aberrant conduction tract. And it's curative, 95%. Now, ventricular arrhythmias, VTAC, a wide complex tachycardia, if it's unstable, you shock. As with all arrhythmias, ischemia is the most common cause, or any damage to the cardiac myocardium or cardiomyopathies. Arrhythmias can also be caused by electrolyte disturbances like potassium. Now, in VTAC, you have a wide, complex tachycardia. If it's unstable, you shock. If it's stable, you use medications like amiodarone, procainamide, and lidocaine, but particularly amiodarone and lidocaine. It's a wide, complex tachycardia. If it's unstable, you shock. If it's stable, you use medications such as amiodarone. Now, if VTAC is pulseless, you treat it the same as you would ventricular fibrillation, unsynchronized cardioversion. If there is a pulse and the person is unstable, you shock as well. Now, if it is stable, you can use medications such as amiodarone and lidocaine to convert the person. Now, the dosing is not as important as knowing. If it's unstable, you shock. If it's stable, you use amiodarone, lidocaine, and procainamide. If nothing else will work, you would use cardioversion at the end of these. Torsade is ventricular tachycardia with an undulating amplitude. So it looks like it's twisting around a point. And the only difference about this one is using magnesium in addition to the other medications. VTAC around an undulating amplitude, use magnesium. VTAC around an undulating amplitude, use magnesium. Now, the ventricular and atrial arrhythmias are also covered in the emergency section. So the end of cardiology is redundant with the beginning of emergency medicine as well. So they have the arrhythmias are actually covered twice. They're covered here at the end of cardiology and at the beginning of emergency medicine. I wish you very well in your studies. I am sure that I will meet you again in the future sometime. Until then, I'll see you in the next section.